On At the Forefront Live today, we will discuss paradigm shifts and changes in the measurements used for kidney functionality. Physicians will share the ramifications associated with this new method and how the new quantifier will impact patients, and they'll cover general topics related to nephrology. And, of course, they'll take your questions. That's coming up right now on At the Forefront Live. And we want to remind our viewers that today's program is not designed to take the place of a visit with your physician. Let's start off with having each one of you introduce yourselves and tell us a little bit about what you do here at UChicago Medicine. And Dr. Arlene Chapman, you're actually at the desk with me, so we'll start with you.
Oh, thank you, thank you. I'm Arlene Chapman. I'm chief of the section of nephrology here at University of Chicago Medicine.
All right, and then let's go over to the opposite corner, and this is Dr. Krishnamurthy. Tell us a little bit about yourself.
I'm Sam Krishnamurthy. I'm a transplant nephrologist and I take care of transplant kidney patients here at the hospital.
Great. And Dr. Rita McGill, you're actually in the other corner of the studio. We'll go to you now. Or excuse me, I'm Dr. Saunders, I'm sorry.
Hi, I'm Milda Saunders. I'm a general internist and researcher. And I also take care of patients who want to donate a kidney.
We have a lot of doctors in the studio and a lot of people in the studio today. We actually have 5 guests, which is fairly unusual for the program. We're going to shuffle people on and off. And again, we're trying to do this to the best of our ability and keep people separated due to COVID protocols. So that's where some of the confusion, and plus it's just me, so that's the other part of the confusion. Let's talk a little bit about EGFR. And Dr. Chapman, I want to start with you on this one because I think that's a term or it's terminology that people with kidney issues will understand, but a lot of folks that are watching have no idea what that means.
Sure, absolutely. And the letters EGFR stand for estimating glomerular filtration rate. And really, the purpose of the kidneys is to filter waste from the body. And so how we know that the kidneys are working is by determining the rate at which we filter those wastes. And so it's a moving target. During the day. We can change our GFRs 10 to 15% depending on if we're exercising, if we're having dinner, if we're drinking a lot of fluid, if we're going for a long hike without a water bottle. And so it is a number, but is it a number that moves around during the day within an individual?
I would imagine that would make it challenging for you as a physician with that much of a fluctuation with those rates to determine what's healthy and what's not.
Correct, and that's why we have some ranges for what's considered normal and some ranges for what's considered kidney disease. And this is where these estimating GFR equations become very, very important and understanding the concept of what they really represent for a patient.
Dr. Saunders, I want to ask you a question because this is fascinating to me. I had no idea that we used race as a basis with these numbers. Can you tell us a little bit about the history of that and then shift to why we're changing?
Sure. I think as society and science evolves, we remember that race is a social construct. That is, it varies based on your history, where you're from, and your personal history. And we've used that as a proxy for other factors in some of the equations that we use to make decisions. We have decided to take a step back and actually rethink that and try to have a race-free measure in our equations, because a lot of the measures like gender or age are things that are true and measurable where race is not.
So as we change that now, how much of an impact will that have? And we'll get more into detail, I know, as we move on throughout the show, but how much will that actually impact the individual patient? And it'll have a farther-reaching impact or further-reaching impact as well, right?
Absolutely. So patients will have what is a minor adjustment in their calculated or estimated EGFR, but that is important in that it may make some patients eligible for kidney care or be classified as having chronic kidney disease when previously they were right on the border. We think that's important because they'll get all of the things that will help treat and prevent chronic kidney disease progression.
And Dr. Krishnamurthy, if you can talk to us a little bit about patient care in general for these folks that are dealing with these issues, because it's a pretty significant basically a life issue for folks. This is something that oftentimes it can last for a long time with these patients, correct?
That is true, and there are different watershed lines, so to speak, in chronic kidney disease, which helps us physicians to understand which direction and how fast their kidney disease is progressing. To give an example, usually a number of EGFR of 60 is considered where we would, less than 60 is where we would tell someone that they do have chronic kidney disease. Less than 30 is where they should definitely, by the time they get to 30, be seeing a kidney doctor, and they may need specific management, specific treatments because of the effects from their kidney disease. And around 20 is when they have to be referred to a transplant center. And so during the whole lifetime or the natural history of chronic kidney disease, anyone who's around these sort of watershed or borderline or important markers of where their kidney function is, change in the equation, though minor, could put them on either side of that line and impact their care.
So we have a graphic I think we're going to show here. And before we show that graphic, though, well, we can go ahead and show it. And if you can tell us what CKD, that's chronic kidney disease,
Right.
and their various levels, the EGFR levels, can you explain and tell us what that means and kind of walk us through that? I don't know who wants to take that one. I'll just throw that out there to anybody who's interested.
So I can start off and,
Sure.
and everyone can join in. So we have 5 different stages for chronic kidney disease. So some people are born with a kidney problem and their kidney function is completely normal. So they still have chronic kidney disease, but they are stage 1. So their estimated GFR, that measurement of kidney function, is more than 90 ml per minute.
And would you even know that if you were that patient, or is that?
Well, that's a great question. It depends. You know, some of the people that have normal kidney function and a kidney disease have a hereditary condition.
Mm-hmm.
So they know it's in their family and they find out that they have it, even though their kidney function is still normal. And that is not that is a good thing, because there's lots of preventative things that we can do even early on to prevent patients from losing kidney function. So we really encourage to have people find out whether or not they have a kidney disease or not.
Sure.
It's tricky because chronic kidney disease is quite silent. People get a blood test, that's what tells us whether or not they're CKD 1, 2, 3, 4, or 5, and they don't feel very different. So it's so hard to make it the point to them that this is something worth addressing and taking care of.
Well, I would imagine oftentimes people, if they don't realize that there is an issue, they let it get worse and worse before they get treatment, which is never a good thing.
Correct. I think there's other conditions that people are much more worried about and pay attention to, cancer being one of them, heart disease being another, and kidney disease is a really important, serious condition.
And it's a huge quality of life factor.
Yeah, absolutely.
So we do have questions coming in from viewers, and I do want to remind viewers, if you type your questions in the segments, the comments section, we'll try to get to those with our room full of experts that we have here today. So I'm going to do my best to try to pronounce the words correctly in this one, because this is a little bit of a challenging one for me. This is from a viewer who said, I've had bad kidney counts due to, looks like tacrolimus. Am I close?
Yes,
Yeah.
very
Great.
good.
Have you had patients go on the, and now this one, I may only be 1 for 2, the belatacept infusion? I am a lung transplant recipient. So,
And Dr. Krishnamurthy's.
Greg, you want to take that one, Dr. Krishnamurthy?
Absolutely. So I think that would definitely be a conversation with your lung transplant physician. In kidney transplant patients, we have used belatacept to minimize the dosing of tacrolimus, so that way we can prolong their kidney function in the long run. But based on your personal history, it would be important to talk to your lung doctor whether belatacept is safe for you in the long run.
Interesting. Great. Next question that I had on my list was, how do particular EGFR values determine when a patient should be referred to a transplant team for evaluation to receive a kidney donation? And I don't know, Dr. Saunders, would you want to start us off on that one?
Sure. So they're different, as Dr. Krishnamurthy said, they're different cut points. And so at less than 60, or stage, that's when we would refer to nephrology ideally, but a lot of that is managed in primary care. At less than 20, and maybe even a little higher, we want to start talking about renal replacement therapy, and the ideal one is kidney transplant. And so that would be when you would really start thinking about kidney transplant and want to be referred to a transplant center. even before that, you'd want to start thinking about a living donor and start talking to friends and family members.
Well, and if you wouldn't mind delving into that just a little bit more, because we do some pretty exciting things, in particular with kidney transplants now and living donors, and it's really, I think, kind of a game changer, some of the work that happens here at UChicago Medicine as far as making that as easy as possible, in particular on the donor. Can you talk a little bit about that?
Absolutely. So we know that the best way to maintain your health is to have a transplant, and the fastest way and the most long-lasting way to have a kidney transplant is to have a living donor. And we at the University of Chicago try to make sure, well, we do make sure that all the donors who, potential donors who come in are informed about the process, they are healthy themselves, and have kidney function that can tolerate actually them only having one kidney, so that they can continue to live a long and healthy life while still helping a friend or family member.
Great. And we were talking a little bit before the show actually started, Dr. Chapman, and I'm kind of curious because these EGFR numbers, this is a little confusing to, I think, a lot of folks. And Dr. Saunders touched upon this as far as the history and then the changes. And I guess the impact is really what I'm kind of curious about, not only to the patient, but how about to the medical center and the medical team, because it will impact your work as well, correct?
Yeah, and I think we'll get into this a little bit later in the show as well.
Sure.
But right now, and this is probably going to change in the next couple of weeks, we have two reporting equations for estimated GFR. One for African Americans and one for individuals who are not African Americans. And as Dr. Saunders so rightfully points out, it's very difficult to identify that appropriately. And whether or not it really contributes to that particular number in a differential way is, as we've talked about, because of the variability of the measurement, probably not the biggest impact. And so I think what we'll see when the reporting changes is that we'll have one number for all. And it's going to be called EGFR all. And so for people who had previous numbers, this may change a little bit, and that's where we're going to be doing our due diligence to make sure people understand that actually that serum creatinine measurement, the blood test that we do, it's exactly the same. It's just that the equation has changed a little.
And that's happening really soon.
Yeah, it should be happening before the end of this calendar year.
Oh, that's great, and it's it's a big change for the institution, but hopefully will benefit a lot of folks out there.
Yeah.
So another question that we had: how does a particular EGFR value determine whether someone can or cannot donate a kidney? I know we touched on that a little bit, Dr. Saunders, but Dr. Krishnamurthy, I want to throw that one to you. As far as when you look at those patients and you see the different levels, I'm sure there's some that are probably easier to use and to work with than others.
So usually for living donors, the EGFR cutoff that we use is about 80 to 85, so that we are confident that they're left with enough kidney function for themselves after donating a kidney. So depending on whether you are African American or not, using the old equation could overestimate what your EGFR is, whereas for a non-African American patient, it may underestimate what your EGFR is. And this applies to those patients who are near the cutoff of 80 to 85. So again, the impact is always around sort of the watershed or borderline numbers. So having a EGFR all eliminates that kind of binary division, especially because the world is getting smaller and we're seeing patients, donors from a wide variety of ethnicities and backgrounds, and it does not make sense to have these two different values based on race.
So we've talked about living donors. How about deceased donors? What is the difference as far as the value of the kidney? And I know that's probably not the proper word to use, but.
So living donation, like Dr. Saunders mentioned, is definitely sort of the gold standard of kidney transplantation. The average wait time for a kidney transplant in the US is about 4 to 5 years. So if you're able to get referred to a kidney transplant center when your GFR is close to 20, the advantages of having a correct EGFR measurement or a fair EGFR measurement is that we already have a lot of existing disparities. So having a fair value means our African American patients who are already socioeconomically disadvantaged are able to get a fair process to get referral to a transplant center on time. That gives them more time to gain on not only on the deceased donor list, but also time to look for a living donor. By gaining or by obtaining a living donor kidney, the outcomes or the long-term function of the kidney lasts many more years than a deceased donor kidney. So especially for all patients, getting a living kidney donor really improves their outcome in the long term, giving them longevity, not just for all patients, especially for younger patients. That makes a big difference.
You mentioned the longevity of the kidneys. If you do receive a kidney from a living donor, for example, what's an average that someone can expect to?
So the half-life, so to say, roughly, of a living kidney donation is about 15 years or to 20 years. Mm-hmm. And with each decade, we've been making more progress. So compared to 20 years ago, the living kidney allografts that we're doing now are lasting longer.
Well, that's fantastic news for those recipients, and that's great. Another question from a viewer. I have CKD level 3. I know it's not that bad. This is Kim that's asking this. My GFR is less than 40. Is diet the only way to maintain this level? Thank you for the question, Kim. I don't know who wants to take that one.
Oh, sure. So
Go
as a primary care doctor,
yep.
We see a lot of patients just like you who have stage 3 chronic kidney disease. And at stage 3, the things that you can do are the things that your doctor's already telling you to do. So managing high blood pressure, making sure that diabetes is under control, stopping things that could further harm your kidney, like cigarette smoking, taking ibuprofen or Aleve. And this is ideally the time when you want to be referred to a kidney doctor. But even if you stay in primary care, it's important to do all of those things so that your current kidney can remain as healthy as possible for as long as possible. I think diet is important, but I think it helps to control all of the other conditions that can lead to kidney problems or progression of kidney disease.
Healthier lifestyle. And we always say, please do not smoke. That impacts everything, and certainly, as you just mentioned, not good for your kidneys as well. What are some diet modifications that a person might make?
So I guess I'll
this one's
start
for you.
with that. Yeah. So I think some important diet modifications are the things that we all say are part of a healthy diet. Maintaining, having fruits and vegetables, reducing salt in diet, reducing fats so that you can maintain a healthy weight, fats and sugars so that you can maintain a healthy weight and help your diabetes be under better control, having a consistent complex carbohydrate diet, again, to make sure that diabetes is well controlled. But I also want to stress, diet is very important, but you want to take medications in addition to diet to help control conditions. Those two things go hand in hand.
And you mentioned some medicines that are pretty common a moment ago. And you're saying people should not take those or should avoid those if at all possible?
So I think people with chronic kidney disease should avoid ibuprofen or Aleve. You know, we say that if people take it once a month for a headache or something like that, but most of us don't take it like that. We sort of take it multiple times a day over multiple days. And with chronic kidney disease, we really want people to avoid those medications and try Tylenol, acetaminophen for aches and pains that they may have.
And there's an issue, I think, oftentimes where people take too much of those medications because they don't think they'll damage them, and not only can they be bad for your kidneys, but also your liver doesn't particularly like it either. We're going to take a quick break because we have a couple of other experts that we want to get on the program to talk a little bit about some of the science behind this. So let's take our break now, and when we come back, we'll have 2 more experts joining us.
We put your safety at the forefront. With remote check-ins, required face masks, required wellness screenings, social distancing in waiting rooms, disinfected clinical areas, and video appointments. Because your health needs don't stop, and neither do we. Schedule a safe in-person visit or video appointment today. UChicago Medicine, at the forefront. We put your kids' safety at the forefront. With remote check-ins, required face masks, required wellness screenings, social distancing in waiting rooms, disinfected clinical areas, and video appointments. Because your kids' health needs don't stop, and neither do we. Schedule a safe in-person visit or video appointment today. UChicago Medicine Comer Children's, at the forefront of kids' medicine. We put your safety at the forefront. With remote check-ins, required face masks, required wellness screenings, social distancing in waiting rooms, disinfected clinical areas, and video appointments. Because your health needs don't stop, and neither do we. Schedule a safe in-person visit or video appointment today.
And welcome back. We have a couple of new guests that are joining us right now. And Jerry Yao is director of our clinical chemistry laboratories. And I found out that you're our neighbor. You're just right down the hall from us, if I'm not mistaken. Is that correct?
Yes.
Yeah. So you're very close to the studios. I thought you were down there. And then Rita McGill also joins us. Dr. Rita McGill, who is well. Let me actually ask you guys to tell us kind of what you do here. And Dr. McGill, we'll start with you since I already talked to Dr. Yao.
Okay. I'm Dr. Rita McGill, and I am a member of the section of nephrology, which means that I see kidney patients in the outpatient clinic, I see kidney patients in the hospital, and I also take care of a lot of kidney patients at my dialysis center on 95th.
Oh, okay, yeah, you were talking about that before the program. Tell us a little bit about how do GFR values compare before and after the change to this GFR all that we were hearing about moments ago with Dr. Chapman.
The previous situation was that there was a 16% difference between the two values. So this could certainly move you from one side of a cut point to the other side of a cut point. And that's kind of problematic because, as it says in the name, estimated GFR is an estimation. Unfortunately, measuring a GFR is sort of an arduous process that takes several hours with the collection of urine specimens and a pair of IVs. I've been through that. I don't really recommend it. So estimations are a wonderful tool that allow us to use a very common, easily available, and inexpensive test to estimate kidney function, but it is an estimate. And so we're always reassessing that, always trying to do a better job and make those estimates reflect the reality of our patients. And the change is that a 16% change in your results based on the color of your skin is going away.
Interesting. So I mean, that's a pretty significant number. So when you talk about the cut lines on either side, be a little bit more specific as far as, I think I know what you mean, but tell our audience what exactly that will mean for patients.
Okay. Well, I was thinking about a patient that I saw rather recently in the kidney clinic, a 55-year-old woman who had a serum creatinine of 1.12, and she happened to be white, and therefore her calculated GFR was 56. If she had been African American, her calculated GFR would have been 64, with the same age, same sex, and same serum creatinine level. That definitely would have moved her to the other side of the cut point at 60. The GFR all equation would have used these parameters and put everyone at a calculated GFR of 58, and therefore everyone would get care.
Oh, interesting. So some real positive potential then with this. So Jerry, does the type of creatine test and its reproducibility affect the EGFR value?
So let me quickly do a quick introduction as to what I oversee. I oversee the clinical chemistry lab at the UChicago Medicine. This is where we get all the blood sent down, ordered by our clinical colleagues, and we do all the creatinine tests. Obviously, we do the creatinine test. We get a a lot of them per day, hundreds and hundreds of them. So we do it on a very precise automated analyzer. And we have moved to a very precise assay, as we said. There are many different kinds of creatinine assays out there that are FDA approved. Some are more precise than the others. And out of this single measurement of creatinine in the blood, we put it through a very complicated polynomial equation to calculate the EGFR. And currently, we use the state-of-the-art creatinine assay that has very low variability of around 2.4%, which is extremely good. It is a state-of-the-art. But when you put through the equation, even with that precise variability, there's still somewhat of a variability in the EGFR calculated value. It depends on the age and the gender of the patient. It could vary anywhere up to about 7.4% on the high side, and the low side will be about 5% or lower. That's the nature of the business. So by choosing the assay that is standardized to the gold standard method, which we do, and choosing one that is very precise, we are trying to get as accurate as possible an EGFR measurement to our clinical colleagues for them to make the decision.
So will this lead to changes within your laboratory? Is this I imagine this is a fairly significant deal for you.
Well, the method itself has not changed. It's the calculation that have changed. So we are right now in the process of instituting the new equation. Obviously, we are targeting to go live hopefully sometime next week once the IT checks have been all done, because it's a very complicated process. Even though we are just changing an equation, it takes a team to make sure that everything is done properly, and it download from the clinical orders all the way to the lab, is received, is measured, and is uploaded accurately so that the clinical decision process can go on.
So this is interesting because it impacts people and the organization just in a pretty significant way. If I'm a patient and I want to see those numbers and know that information, is there a way that I can check that in my chart or in Epic?
Yeah, it will be all, once it's uploaded seamlessly, it will be displayed below the creatinine result, like what they are seeing it on my chart.
Well, and I guess so the question and part of the purpose behind doing the program is don't be surprised with some changes, because there likely will be, I would imagine.
Right.
Great.
Exactly.
So Dr. Miguel, I'm curious, does the change in the GFR all values from the prior EGFR value, it doesn't really mean a real change in kidney function, it's more just a look at how that kidney function actually operates. Is that accurate?
That's absolutely correct. The E in EGFR stands for estimated, and so the estimation allows us to make a sensible estimation of the actual filtration speed. When we use the serum creatinine by itself, it's the traditional lab for assessing kidney function, and it is very cheap and convenient, but it's very, very difficult to use. For example, it's a value that goes up when the kidney function goes down. It doesn't do so in a linear fashion, it does so in a curved fashion. And then if that wasn't bad enough, the serum creatinine for any individual is a function of their muscle mass, the amount of protein that they are consuming, and it makes it extremely difficult. So before we had estimating equations, it seemed as though kidney specialists like myself were the only people who could understand creatinine at all. So the estimating equations brought a much better sense of kidney disease to everyone, the rest of the world, other physicians, primary care, to patients. And so they're a wonderful thing, but there's always room for improvement. So what's changed is the estimation. So you may find that as a patient, you now have a different number, and yet your creatinine didn't change. And what it really means is that we're beginning to move closer and closer to a better estimation for everyone.
Fantastic. We are about out of time, but we do have one more question from a viewer. And Dr. Chapman, I think I'll give this one to you because I think it's a good question. So Lawrence is asking, have you seen an increase in CKD patients as a result of the COVID pandemic? And what can patients do to protect against the risk associated with COVID infection and specifically CKD patients?
Sure. So we have seen an increase in the number of patients who've developed kidney problems from COVID, no doubt about it. The biggest problem has been rather an acute kidney injury, which often resolves and the kidney function comes back over a period of time. But we know now that anyone who's had an episode of acute kidney injury down the road is at risk for chronic kidney disease. So we really want those folks to be followed by their physicians closely with our best estimating GFR equation that we can use so that they get the right medications, the right blood pressure goals, and the right dietary information.
And kind of the standard COVID messaging for those folks as well, to take care of yourselves and make sure you wash your hands often and mask, I would imagine, and probably
Socially distance.
A vaccine would not be a bad idea.
Would help.
Yeah. Great.
Absolutely.
We are out of time. You
Good.
guys were fantastic. Thank you for being with us today. And a big thank you to those of you who watched and participated in the program. Please remember to check out our Facebook page for our schedule of programs that are coming up in the future. To make an appointment, go online at UChicagoMedicine.org, or you can give us a call at 888-824-0200. Thanks again for being with us today, and I hope everyone has a great weekend.